We're from SBCE 619, Section 817. And I'm going to start off our introduction from the pro side. Um, we propose that the biopsychosocial model should replace both the social and the medical models, as neither are sufficient on their own. The biopsychosocial model provides a comprehensive framework that offers a holistic approach, systematically examining the interconnected biological, psychological, and social factors that influence the lives of individuals with neurodivergence. While the medical model has its flaws, completely discarding it would be detrimental. It remains essential for research on ASD and for securing resources for those with a medical diagnosis. When the BBS model is implemented correctly in healthcare and in education, each domain has careful consideration. This isn't about fixing the individual, it's about fixing the environment along with targeting the other influencing factors, i.e., biological and psychological. Our side also centers on two crucial practices, normalization and person-first language. Normalization in specific contexts can have its place in terms of balancing individual autonomy with cultural expectations. We must take into account the diverse beliefs and family dynamics when providing care to our clients. Ignoring these norms can lead to significant consequences, especially for marginalized families like Black families who may need to prioritize societal norms for their children's safety. Finally, using person-first language is fundamental to respect. It recognizes that a person's identity can vary depending on the individual's personal history. Professionals must avoid assumptions, treat every individual with dignity, and understand them as a whole person with a unique history.
Thank you, Megan. And then Liz and I are going to be arguing that disability should not be framed primarily around normalization of person first language. Instead, we believe that disability identity should be affirmed and that disabled voices should be centered in every conversation about disability. At its core, our position is about valuing diversity, autonomy, and lived experience. When we affirm disability identity, we recognize that disability isn't a flaw to be corrected. It's a natural and meaningful part of human variation. This approach fosters authentic representation, community pride, and self advocacy. We will present three main arguments to support our position. First, framing disability around normalization or the medical model often pathologizes differences and places control in the hands of professionals rather than the individuals themselves. This approach can inadvertently pressure disabled people to conform to neurotypical standards rather than honoring who they truly are. Second, affirming disability identity strengthens community, self advocacy, and social inclusion. By centering disabled voices, we give individuals the power to define their own identities and experiences, fostering pride, representation, and authentic participation in society. Third, the common practice of using person first language while well intentioned can unintentionally imply that disability is undesirable or separate from the self. Many self advocates prefer identity first language because it affirms their identity and supports autonomy. Throughout this debate, we will also highlight the ethical implications of these approaches, demonstrating how affirming disability identity aligns with principles of respect, dignity, and client-centered practice. Finally, we will show how these ideas can be practically applied in ABA and other interventions, ensuring that services are not only effective, but also empowering and inclusive. In conclusion, our position is clear. Disability is not a problem to be fixed, and people should not be asked to fit in society's narrow definitions of normal. Instead, we must honor lived experiences, affirm identity, and center the voices of disabled individuals in every conversation and intervention.
All right, so now we're going to get into our main argument one from the pro side. So the biopsychosocial model is an essential framework for effectively addressing complex ethical dilemmas, especially in behavioral health, the workplace, and in schools. We are arguing for a system that actively considers all three domains, the biological, the psychological, and the social. So in my Venn diagram, I've identified several key variables within each domain. Some of these factors are interconnected. For example, emotional regulation overlaps with both the biological and the psychological, while medical diagnosis, securing rights to resources, funding, and accommodations overlap with both the biological and the social domains. And I've used the sources of Coles-White 2024, Hudson and Hudson 2023, Srini-Vasan's 2025, and Welpley 2023 research to construct this Venn diagram. The advantages of adopting this framework are urgent and clear. First, it is comprehensive. Unlike the social model alone, the BBS model successfully incorporates essential medical considerations and biological research. More critically, neglecting the biological domain can have serious consequences, and here's why. So, what I'm about to talk about comes from Serini Vasan's 2025 research, and they highlight that the significant shift away from the medical model can foster a dangerous cycle of distrust. So, more specifically, when proportions of the neurodiversity movement strongly oppose medical research, their philosophical stance removes the incentive to fight these exclusionary rules. And what I mean by this is researchers and drug companies face no pressure to adapt trials. And as a result, autistic individuals are often explicitly barred from major clinical trials for common co-occurring conditions such as depression and ADHD. This systematic exclusion, perpetuated by strict eligibility criteria, severely limits the scientific evidence available. The anti-medical stance unintentionally perpetuates the very gap in health knowledge it claims to address. And then some other things, the biological component is crucial because without a correct medical diagnosis, individuals struggle to access necessary services such as accommodations and other resources. Beyond access, research shows that individuals with autism have a significantly reduced life expectancy, with a compelling data on this mortality gap published in the Lancet Regional Health 2023. This is primarily due to severe health inequities experienced by persons with autism, which results in under-recognition and under-treatment of physical health conditions. Symptoms like chronic pain are frequently dismissed as just a part of autism or solely attributed to behavior. We simply cannot afford to ignore the biological domain when people's lives are at stake. And now I'm going to get into some of the common critique of the BBS model, and this comes from Doom 2020. So the common critique is that it's too vague and thus not testable. However, the same source, Doom 2020, created the testable BPS pathways model. This solution breaks down abstract outcomes into measurable components, similar to how we as behavior analysts will operationalize behaviors. And then if we could go to the next visual, please. Thank you. So as you can see in this visual, I've taken a common behavior that we as behavior analysts might see, such as SIB, and have broken it down into those three domains into quantifiable metrics. This operational approach ensures that clinicians cannot overemphasize the biological domain. By demanding equal measurable components across all three factors, the BPS pathways model makes the framework scientifically sound and prevents reductionism. Crucially, the BPS model is successful because it integrates the social model. It acknowledges that environment plays a critical role and that society has a clear part to play in making adjustments, and that the responsibility shouldn't solely fall on the individual with neurodivergence. The BPS model provides a testable, scientific roadmap that moves us towards a truly inclusive and ethically sound society.
Thank you, Megan, for presenting the biopsychosocial social model as a holistic approach. While the BPS model does integrate biological, psychological, and social factors, we have significant concerns. First, the medicalization trap. Even within a supposedly holistic framework, the BPS model still prioritizes diagnosis and biological explanations. This reinforces pathologizing views of disability, keeping control in the hands of professionals instead of the individuals themselves. In practice, this can unintentionally uphold medical authority over the disabled lives rather than centering the lived experiences of disabled people. Secondly, the dilution of social change. The social model of disability directly addresses systematic oppression and societal barriers. Adding biological and psychological layers risk shifting the responsibility for accessibility and inclusion back onto the individual, weakening advocacy for systematic reform. Third, the deficit bias in research. Evidence-based practices tied to the BPS model are often applied with the goal of fixing or treating autistic people, rather than creating environments that value difference. This reduces autonomy and can undermine the dignity of disabled individuals. Finally, the so-called social component of the BPS model is often tokenistic. It's sometimes included merely to justify medical dominance rather than genuinely centering disability rights or lived experiences. While the BPS model claims to be comprehensive, it still perpetuates a medicalized deficit-focused view of disability. And that's exactly what we're cautioning against. And with that, I'm going to move into our first argument and for the con side, which is going to be the critique of biopsychosocial and medical models. And Liz, I think this is your point if you want to take that one.
Yes, sorry. So the medical model prioritizes neurotypical frameworks. So the problem, the historical approach, it wrongly frames neurodivergence as disordered or other, causing the medical model to exclude neurodivergence perspectives and view them only in contrast to neurotypical norms. Um, this is unethical as it frames neurodivergence as abnormal and dehumanizes neurodivergent individuals by positioning them as objects to be corrected rather than as subjects whose experiences merit understanding and respect. Solutions to approaching uh, scientific studies with neurodivergent individuals would be to reject models or theories that frame neurodivergence as inherently disordered. Um, Also, to not assume that uh, samples, sorry, are should or should not be just neurotypical, and then led promote neurodivergent led research and community involvement. Um, on the side of solutions for unethical approaches would be to emphasize neurodiversity as differences and not deficits. Neurodiverse people tend to explore differently than neurotypical people, and exploration is part of discovery that is new and inclusive research.
Okay, so I am going to be countering Liz. So while I understand your argument regarding a shared disability identity and how it strengthens advocacy, however, we must consider its critiques. The social model's heavy emphasis on unified disability identity can have its issues. This framework often relies on Western individualistic perspective, and this has been cited by Ellis 2023, Coles-White 2024, Serini-Vassan 2025, and I must highlight that these sources are primarily in favor of the social model, and they have pointed out this individualistic approach. But as researcher Ellis 2023 points out, identity is not static. It is fluid and it is deeply shaped by family and community. By framing identity as a fixed personal attribute, the social model can unintentionally ignore collectivistic cultural values and exclude individuals whose primary sense of self is tied to their community. Additionally, in practical settings, this oversimplification has real-world exclusionary consequences. And from Serini Vassan's 2025 research, they highlight that in the workplace, the social model is often co-opted by corporations. It is used to celebrate marketable traits of neurodivergence, things like hyperfocus and pattern recognition. This can marginalize those with higher support needs, thereby prioritizing individuals whose strengths can be easily monetized. As a result, the social model can fail to account for a rich diversity within the neurodivergent community, leading to inequitable outcomes and ultimately undermining its goal of social inclusion. Also, the BPS model does not focus on deficits in the sense of making a person with autism seem less autistic. It focuses on pathologies and health impairments that prevent dignity and self-determination. For example, we do not intervene on stimming if it provides comfort for the person. However, we have an ethical duty to intervene on co-occurring conditions, such as severe anxiety. While behavior analysts don't treat pathology itself, but we can design behavioral programs that target coping skills, as an example, that address functional outcomes of that anxiety. And so now we'll be getting into the pro min argument two, and that will be Carly. I think you're muted.
The pro argument, side main argument two. The normalization of behaviors ultimately involves carefully analyze the benefits risks when applying biosocial BPS model, which consider all three domains, biological, psychological, and social. It may require collaboration approach rather than merely individualistic one. This approach depends on the individual and their family dynamics. Normalization methods may be relevant in the collective culture through client anatomy is important principle supporting neurodiversity often reflects Western ideals, potentially conflicting in collectivist values. For instance, a case by Coles White ETL 2024 shows a family preferring their child not to be unclothed at their home, requesting a behavior analyst intervention. From a medical model perspective, the professional might prioritize the family wishes. Conversely, the social model may emphasize individual automatically. Both viewpoints are valid. However, using a more comprehensive framework allows professionals to set asides bias and consider all three domains effectively, especially a balanced and cultural responses strategy might entail considering the individual anatomy while also taking the family cultural context into account. For instance, the analyst could explore a solution where the client is allowed to be unclothed in a specific setting, such as the privacy of their room. From strictly social model perspective, this resolution may seem unjust for not adhering completely to individual autonomy. However, diverting from group norms can lead to significant social consequences, such as isolation from family and friends. These consequences could negatively impact the client's social development, as family members and peers often serve as valuable social models and primary support system. Moreover, the sources mentioned as even more pressing situation involving Black caregivers, teaching their autistic child to indicate their diagnosis for safety purpose. From the viewpoint of the social model, this could be interpreted as normalization and ableism. However, the author's is at crucial precaution in world that is fundamentally racist and present a heightened danger of police violence. They contended that of Black families, these safety worries might take persist over idealistic views of neurodivergent existed over idealistic views of idealistic neurodivergent exist in society. This examples that the neurodivergent movement perspective may be influenced by privilege, indicating that what is deemed as ideal anti-normalization approach is a luxury that not every family can afford. So yeah.
And then we'll get into the counter of that argument from the con side.
Normalization often forces masking or suppression of authentic behaviors, which leads to psychological harm, burnout, and stigma, according to Botha and Gillespie 2022. Appealing to culture to justify normalization risks excusing systematic ableism. True safety and inclusion comes from changing society, not pressuring disabled individuals to conform to neurotypical norms. And normalization, even when well-intentioned, this is also going to loop into our argument too, because we do talk about the critique of normalization practices. And normalization, even when well-intentioned, pressures disabled individuals to conform to neurotypical terms, which harms identity, mental health, and autonomy. Masking and psychological harm, it requires their behaviors to be hidden or suppressed, which again leads to burnout, anxiety, and the loss of self-esteem. Shift societal responsibility because you're expecting disabled individuals to fit in society, avoids addressing the structural barriers or promoting the acceptance within the community. And then the tokenistic cultural sensitivity is appealing to family or cultural values can be used to justify erasing the authentic behavior rather than fostering real inclusion. Coles White 2024 talks about the cultural justifications for normalization because it reinforces systematic ableism. And behavior analytic intervention should focus on safety and autonomy and not conformity. Society should be the ones that adapt to the spaces, expectations, and policies to accept diversity and not demand normalization from persons with disabilities.
Okay, and then we'll get into Khan's side's main argument too.
Let me go.
ABA is designed to help everyone no matter what race. There is no discrimination with the clients. The client are treated equally. Every clinic always follows the ethics to sustain a safe and positive environment. In the Code of Ethics books, it states that treating others equitably, regardless of age, race, gender, ethnicity, national origin, and religion. Code of Ethics, page 4. This proves that clinics treat every client the same, no matter who they are. That should be the number one rule.
All right, then I can transition into the pro side's main argument 3. We affirm the use of person first language, or PFL, as it reflects a more respectful, inclusive, and culturally responsive way of referring to individuals with disabilities. Person first language emphasizes that disability does not define a person's identity. It positions disability as just one attribute among many, just like age, profession, or personality traits. For example, saying a person with autism rather than an autistic person places the individual before the diagnosis, reinforcing their humanity and intersectional identities. The core aim of PFL is to reduce stigma. By separating the person from the condition, this language choice actively resists the long-standing tendency to equate disability with deficiency. It shifts focus from what someone is diagnosed with to who they are, a person first. Advocates for PFL rightfully argue that it centers on personhood and dignity. In clinical, educational, and professional contexts, this is especially important as language influences how people are treated. Dehumanizing language can shape bias and reinforce barriers, while PFL promotes empathy, equity, and respect. Moreover, cultural context matters. Different cultures hold different beliefs surrounding disability. Some view it through a medical lens, others through a social or even spiritual one. Because no single perspective is universally correct, practitioners must adapt their language to align with cultural values. And in many cases, that means using person-first language. It's a key element to being culturally responsive and respectful in diverse settings. In short, person-first language is not just about words, it's about the values those words express. It affirms identity, reduces stigma, and supports inclusive, respectful practices across cultural and professional contexts. Thank you.
Okay, and then we'll get into the counter of that.
Awesome job, Kate. The person first language, it emphasizes that disability does not define an individual and is culturally responsive. It reduces stigma by separating the person from the disability, according to you all. Identity first language reflects self-advocacy and autonomy. Many disabled individuals explicitly prefer identity first language, like autistic person, because it affirms that disability is an integral and valued part of their identity. Using first person language can suggest that the disability is undesirable or something to be separated from reinforcing stigma instead of reducing it. According to CAP 2020, it emphasizes that identity first person language supports self-pride, confidence, and authentic self-expression. First-person language often reflects neurotypical or professional comfort rather than the expressed preferences of the disabled community. Professionals may default to first-person language because it aligns with training or convention, not because it respects the voices and lived experiences of our disabled people. This creates a power imbalance where professionals dictate language rather than the clients or communities. Society does not use first-person language for other identity categories. We don't say person with blackness or person with womanhood. Applying first-person language uniquely to disability reinforces ableist assumptions that disability is something inherently negative or undesirable. BACB Ethical Code 107 requires behavior analysis to respect cultural values, client preferences, and community norms. Ignoring identity first language violates these standards by prioritizing professional convenience over client dignity. ABA interventions, documentation, and communication should center client preferred language, fostering respect, autonomy, and inclusion. In conclusion, while person first language intends to reduce stigma, it risks erasing identity, reinforcing bias, and censoring professionals rather than disabled communities. Identity first or client preferred language is more ethical, inclusive, and aligned with authentic self advocacy.
All right, and then we'll be getting into the con side 3 argument.
And so for con side, main point 3, we talk about the disability identity and self advocacy claim. That disability should be framed as an integral part of a person's identity, not something to separate or normalize. Censoring disability identity fosters authentic self-representation, pride, and advocacy. First, we believe that affirming disability strengthens self-advocacy and confidence. Identity first language affirms that the value of a disability as a meaningful aspect of identity and not a deficit. Research shows that affirming disability identity promotes confidence, social engagement, and self-determination. According to Breda 2023 and Brooks and Bates, when individuals embrace their neurodivergence, they are more likely to advocate for their own needs in education, healthcare, and social context. Strategies aimed at normalizing behaviors often lead to masking, burnout, and trauma, according to Botha and Gillespie 2022. Instead of trying to fit neurodivergent individuals into neurotypical terms, interventions should support authentic behaviors while teaching skills for navigating social systems safely. Decisions about language, interventions, and goals should reflect the input of disabled individuals and communities, not solely professional judgment. Social models and neurodiversity frameworks prioritize lived experiences over pathologizing frameworks, which is critical for ethical and effective practice. ABA, applied behavior analysis, should integrate client preferences, identity information, and cultural responsive interventions. Language, goal setting, and behavioral strategy should be co-created with the individual, emphasizing dignity, autonomy, and self-expression, according to the BACB Ethics Code 209 and 107. For example, using identity first language in session notes, staff training, and documentation ensures that respect for identity is generalized across contents, fulfilling the ABA dimensions of generality. In conclusion, disability identity is not a label to separate from the person. It's an essential part of who they are. By centering disability identity and self-advocacy, professionals promote authentic representation, equity, and dignity while avoiding harm from normalization in person-first language. And then next, we're going to hear the rebuttal to the con side, main point 3.
All right. So while it's important to take into consideration the identity labels that autistic individuals like to use for themselves, it's also important to consider cultural contexts. And in different cultures, different sociolinguistic paradigms are used. And so when we're working in professional contexts, it's important to take that into consideration. So it may not always be appropriate to utilize identity first language.
Okay, so then I think we're going to be getting into the standard codes. Is it on the slide? Because I can't see.
Let me see if it's moving over. Okay. Now I feel like it's moving.
It's on con side. There you go.
Okay.
Oh, wait, it needs to be on standard code. Sorry.
Oops.
There we go. Perfect. So now we're going to get into some ethical considerations and standards, and I'll start as the pro side considerations. So the first code, code 1.07 on cultural responsiveness mandates that professionals practice cultural humility and set aside biases. This means we must identify and respect cultural factors that play a key role in a client's life. This code aligns with our argument for flexibility. For instance, we cannot ignore families that value collectivistic harmony or marginalize families that might need normalization methods for self-preservation within a current inequitable system. Ignoring these cultural variables could lead to severe adverse consequences and this is from Colesway et al. 2024. Additionally, this code supports defaulting to person-first language when serving diverse populations. It's a way to avoid making assumptions about a client's identity and inadvertently dehumanizing them in the process. And then the second code, 2.15, medical consultation. This standard requires us to be aware of biological confounding variables. When identifying target behaviors, especially severe ones like SIB, we as behavior analysts must consider biological factors. For example, if a client is engaging in headbanging, our ethical obligation under this code is to rule out a medical factor, such as an ear infection or a toothache or chronic pain, before attributing the behavior solely to a functional assessment of the environment. This approach is aligned with the goals of the BBS model. And then finally, code 2.09 involving clients and stakeholders requires collaboration in all goal and intervention decisions. The BBS model perfectly balances the needs of the clients and the caregivers. Gathering insights about their cultural backgrounds is crucial for understanding how clients and families identify themselves. For instance, do they prefer person-centered focus, or do they identify strongly with their diagnosis? The BBS approach ensures the behavioral plan reflects this collaborative process, making our interventions more ethical, effective, and compliant with professional standards. So then we'll get into con side considerations.
The con side also looks to the ethics code for behavior analysis to affirm our perspective. 1.07 from the ethics code, cultural responsiveness. Behavior analysts actively engage in professional development activities to acquire knowledge and skills related to cultural responsiveness and diversity. They evaluate their own biases and ability to address the needs of individuals with diverse needs and backgrounds, regardless of age, disability, origin, race, religion, sexual orientation, or socioeconomic status. Behavior analysts also evaluate bias of their supervisees and trainees, as well as their supervisees and trainees' ability to address the needs of individuals with diverse backgrounds and needs. An example would be behavior analysts actively seeking to understand the cultural values and preferences of clients and stakeholders, using respectful, inclusive language, including person first or identity first language, depending on the client's stated preference, is part of this. We also look to Ethics Code 1.10, awareness of personal bias and challenges. Behavior analysts maintain awareness that their personal biases are challenges. For example, mental or physical health conditions, legal, financial, or marital relationship challenges. These may infer with the effectiveness of their professional work. Behavior analysts take appropriate steps to resolve interference, ensure that their professional work is not compromised, and document all actions taken in this circumstance and the eventual outcomes. For example, behavior analysts must recognize and adjust for their own bias, including how they would normally or typically communicate about clients.
Okay, and then we will be moving into the core principles and dimensions. And I think Carly will be, oh, sorry, actually, just kidding. The personal biases and how they interfere with professional activity.
All right. For the pro side, for practitioners who are utilizing the biopsychosocial model and identity first language, two possible biases they may fall into is anchoring bias and linguistic bias. So for anchoring bias, they have the possibility to anchor to the medical model due to the inherent ambiguity of the biopsychosocial model framework. There's a risk of overemphasizing that biomedical component, and that's according to Riley, Healy Cullen, Terry Bacon, and Cora. Practitioners primarily trained within the traditional medical model may be particularly susceptible to anchoring bias, leading to a default reliance on biomedical explanations and interventions. This cognitive bias can hinder the effective integration of psychological and social factors in both assessment and treatment planning. And then for linguistic bias is the belief that one's language for referring to disability is the correct language. Clinicians, researchers, and other professionals who have been primarily trained in person first language may exhibit a linguistic bias against identity first language, reflecting the influence of their foundational training and professional norms.
Personal bias that may interfere on the con side would be confirmation bias, which is the tendency to interpret bias in ways that would confirm a behavior analyst's personal expectations of what intervention should work instead of remaining objective. This may cause one to overlook alternative options or possibly miss opportunities to adjust interventions according to a client's data. Another bias that was found was cultural bias, which looks to assuming one's own culture values should not guide the intervention goals. These risk imposing one's own values that do not align with the family's cultural background, and therefore weakening the collaboration and rapport between the family and the clinician.
And next, we are going to move into how the core principles and dimensions of ABA guide the daily professional practice of behavioral analysis.
One of the 7 dimensions that would be appropriate would be effective, because what tools are helpful in understanding to help the client or patient with their behaviors? What are effective ways to help the client with their wants and needs, and how can you have instructional control? What improvement does the clinic needs to have to help the patient with their learning and developmental skills? Having a profession and mannerable manner in the clinic is always important when working with children. For the ethics code of behavior analysts, it's always crucial to have a professional work and ethic in the clinic. Actively working to create a professional working environment that holds the core principles, code of ethics, page 4. This proves that working in a positive and honest environment will help the clients to have a positive behaviors.
And then for the con side, we're going to first start off with our core principle 2, which is to treat others with dignity and respect. Affirming disability identity respects the humanity and self-advocacy of clients rather than treating them as problems to fix. When we talk about the dimensions of ABA considerations, we have a few. Starting with apply, the interventions are socially significant, honoring what matters to the community. So identity first language, for example. Analytic decisions are data-driven. Adapting identity first language is supported by community research and surveys, according to Botha and Gillespie 2022. Generality practices should generalize across contexts, ensuring consistent respect for identity across sessions, documentation, and training. And technological language and procedures are precise and replicable, ensuring staff consistently use client preferred terminology. And when it comes to ethical justifications for rejecting normalization in person-first language avoids psychological harm, masking and enforced conformity, and affirming identity promotes authenticity, pride, and systematic advocacy, fulfilling ethical obligations to support client well-being and autonomy.
Okay. And then this was Carly's visual that went with the affective dimension as well.
So, yeah.
Okay, so we have compiled a list of questions that clients, caregivers, and other professionals and stakeholders may ask about our topic. And talking to our peers, you are welcome to answer some of these questions in your discussion board if you choose to do so, depending on which side you feel more closely tied to, or maybe you feel somewhere in the middle, who knows. So for the pro side questions, we ask, does the BPS model require individuals with autism to be fixed or cured with therapy, or does it make commitments to change the environment first? And then the second question is, how can BPS model guarantee that its evidence-based practices within the medical component will be used to improve the quality of life for the individual, rather than focusing on eliminating stereotypical behaviors to make the person appear normal to society? And then our third question is, if a client expresses that they stim because it helps them regulate, but their parent demands a reduction in stimming, how does the BPS framework guide the professional to prioritize the client's autonomy and well-being over the social demands of the family?
And then our con-side questions are going to be, first, how do you balance social participation with client self-advocacy? Second, how can interventions respect and affirm disability identity while maintaining safety? 3, how do you choose between choosing person first language and identity first language in practice? How can promoting disability identity reduce stigma and improve psychological well-being? How does community input and lived experience improve ABA interventions? And how can practitioners integrate cultural and intersectional considerations to avoid imposing neurotypical? And thank you all for listening to our debate and participating in our questions. The questions will also be left in our discussion board for your answers. And yeah, thank you for listening.
Thank you. I can
Thank you.
provide the concluding statement for the pro side. So, in conclusion, this discussion has shown that no single model, medical or social, can fully capture the broad scope of the autism spectrum. The medical model, while often critiqued, remains valuable. It provides access to funding, ensures evidence-based interventions, and protects against misinformation. At the same time, the social model is essential as it highlights the impact of environmental factors and champions the rights of autistic individuals to live authentically. It reminds us that autism isn't just about deficits, it's about differences. However, both models have limitations. The medical model, when applied rigidly, risks pathologizing natural autistic traits. The social model, taken to extremes, can overlook the needs of those requiring higher levels of support. That's why the biopsychosocial model offers the most holistic approach. When properly applied, as in Doom's 2020 operational framework, it strikes a necessary balance. It prevents an overemphasis on biology, incorporates psychological understanding, and respects social realities. Ultimately, ethical practice requires more than just choosing a model. It demands respect for individual identity, cultural context, and personal choice, whether that's through using identity first language or person first language. Instead of pitting models against each other, let's integrate them, ensuring our approach to autism is as comprehensive, respectful, and inclusive as the people it seeks to serve.
For our con-side conclusion, framing disability around normalization of person-first language limits autonomy, enforces conformity, and risks reinforcing societal biases. Instead, affirming disability identity and centering the voices of disabled communities ensures authentic representation, self-advocacy, and dignity. We talked about the critique of normalization, critique of person first language, and of the BPS model, and talked about the advantages of disability identity affirmations, which is centering disabled voices, strengthens self-advocacy, pride, and authentic inclusion. It ensures interventions respect autonomy, dignity, and community values rather than prioritizing conformity to neurotypical norms. Keeping the focus on dismantling systematic barriers emphasizes that disability is a natural part of human diversity. Society, not the individual, must adapt. Disability is not a deficit to be corrected, it's a value part of human diversity. By affirming disability identity and centering disabled voices, we create a society that respects individuality, promotes justice, and empowers all individuals to thrive as they are.
Okay.
And now that concludes our debate. Everybody, thank you for listening and just taking the time to participate.
Yay.
Okay. I stopped. Let me get my